Bismillah ar-Rahman ar-Rahim. Dear colleagues, it's my pleasure to have this presentation about very important topic, diagnosis and management of syncope from a cardiac perspective. First of all, this presentation is going to cover the definition, classification, pathophysiology, risk stratification, diagnostic workup, and management in brief for different causes of syncope. Syncope is defined as transient loss of consciousness due to global cerebral hypoperfusion and characterized by three features: rapid onset, short duration, and spontaneous complete recovery. On the other hand, transient loss of consciousness is a broader term. It may occur after trauma or without trauma, and it includes syncope as a subtype of transient loss of consciousness, but also includes other causes for loss of consciousness like epileptic seizures, psychogenic causes like psychogenic pseudosyncope, and other rare causes like subclavian steal syndrome, vertebrobasal transient ischemic attacks, and subarachnoid hemorrhage. Let's concentrate on reflex syncope, orthostatic hypotension, cardiac syncope, which are the main causes of syncope from cardiac perspective. First of all, reflex syncope. Reflex syncope is known as also neurally-mediated syncope, and this includes three types: vasovagal syncope, situational syncope, and carotid sinus syndrome related syncope. Vasovagal syncope may occur as orthostatic vasovagal syncope, like prolonged standing in crowded areas in hot weather, or emotional syncope, which is a common type, like after experiencing severe somatic or visceral pain, the patient may lose consciousness and develop what's called vasovagal syncope. The second type of reflex syncope is situational syncope, like certain situations induces syncope, like micturition, defecation, coughing, sneezing. The third type of reflex syncope is carotid sinus syndrome. We know the arterial baroreceptors are located in the aortic arch and the carotid sinus, and if these baroreceptors are hypersensitive, the patient may develop syncope in response to certain situations or maneuvers that we are going to discuss in the next slides. ونفتكر هنا ان reflex syncope, the most common type, neurally-mediated syncope, including vasovagal syncope, situational syncope, and carotid syncope. The most common type of syncope and the most benign type of syncope regarding prognosis. The second type of syncope is syncope due to orthostatic hypotension, and this may occur due to drug, which is the most common cause of orthostatic hypotension, like vasodilators, diuretics. Second cause is volume depletion, like diarrhea and vomiting and hemorrhage, especially in old age. The third cause of syncope due to orthostatic hypotension is related to autonomic dysfunction. And autonomic dysfunction may occur either primary, like primary autonomic failure, multiple system atrophy, Parkinson's disease, dementia, or secondary to systemic disease like diabetes or amyloidosis. So, syncope due to orthostatic hypotension includes drugs, volume depletion, or autonomic dysfunction. The third type of syncope from cardiac perspective after reflex syncope and orthostatic hypotension related syncope is cardiac syncope. And the cardiac syncope may be either related to arrhythmias or structural defects. Arrhythmia BP, as we all know, bradyarrhythmia like sinus node dysfunction or AV block, or tachyarrhythmia SVT or VT. On the other hand, structural cardiac defects are mainly related to obstructive lesions like aortic stenosis, hypertrophic obstructive cardiomyopathy, prosthetic valve dysfunction, or it may be a cardiopulmonary and great vessel abnormality like massive pulmonary embolism or acute aortic dissection. بالتالي, classification of syncope from cardiac perspective includes reflex syncope, again orthostatic hypotension related syncope, and cardiac syncope. Reflex syncope and orthostatic related hypotension syncope are relatively benign, while cardiac causes of syncope are not that benign as reflex syncope. Let's have a look on the pathophysiology of the most common type of syncope, which is reflex syncope. If you look to this figure, this is the vasomotor center. The vasomotor center receives afferent triggers from somatic and visceral triggers, like in response to painful stimuli, or from hemodynamic triggers from baroreceptors in the aortic arch and the carotid sinus, or emotional triggers like fear or the sight in reflex syncope and emotional stresses. The reflex arises from the vasomotor center through the vagus nerve to the SE node, through the sympathetic nervous system, preganglionic and postganglionic. And the net result after stimulation of the vasomotor center through these triggers is vasodilatation, marked vasodilatation in the splanchnic region, and the marked vasodilatation in the lower limbs that results in hypotension. In addition to that, exaggerated vagal impulses to the SE node will result into bradycardia or sinus arrest or asystole. So the end outcome of reflex syncope may be a vasodepressor response, a cardioinhibitory bradycardia asystole response, or a mixture of them. And this is the pathophysiology of the carotid sinus, the reflex syncope, and the situational syncope. This shows the pathophysiology of syncope due to autonomic failure. The trigger usually in autonomic failure starts with hypotension. Hypotension like after prolonged standing or postprandial, or after prolonged bed rest, what's called post-deconditioning. Abnormal stimuli from the baroreceptors in the carotid sinuses and the aortic arch, baroreceptors through the vagus nerve and the glossopharyngeal nerve reaches the vasomotor center. Due to autonomic dysfunction, the impulses, which are compensatory mechanisms to increase the heart rate or to do vasoconstriction, will not work properly due to autonomic dysfunction. And so in response to these hemodynamic triggers, because of hypotension, there is inadequate increase in the heart rate, what's called the chronotropic incompetence, and inadequate vasoconstriction, and this vasodilatation or inadequate vasoconstriction will result in hypotension, in addition to inadequate increased heart rate, and syncope may occur in case of autonomic dysfunction, whether primary or secondary autonomic dysfunction. What about the epidemiology of syncope? The data are derived mainly from general population, like the Framingham study, or patients coming to the emergency department with syncope. In general, reflex syncope is the most common cause of syncope, either in the general population or in the ER. About 21% up to 35 or 48% coming due to reflex syncope. Orthostatic hypotension and the cardiac cause of syncope, both of them represent about 10% from 4 to 20 something. Unexplained syncope in general, about 1/3 of patients. Reflex syncope and orthostatic are relatively benign. Cardiac causes are not benign causes of syncope. Now the patients arrive at the emergency department with transient loss of consciousness. What to do? The first step is to make sure that this patient in fact developed loss of consciousness. Is this a true loss of consciousness or not? If not, so the patient does not have syncope or transient loss of consciousness. If this transient loss of consciousness is non-syncopal from history and examination, like epilepsy or psychogenic, these patients are referred to their specialties. What about patient with true syncope? True syncope may be reflex syncope, orthostatic hypotension related syncope, or cardiac syncope. Initial syncopal evaluation includes proper history and physical examination, ECG, blood pressure measurement in supine and standing position. After this initial workup, you may reach the diagnosis of the cause of syncope with high certainty like you auscultate, for example, severe aortic stenosis, and in this case this patient needs to have treatment started right away. Or after this initial workup, the diagnosis is still uncertain, and in this case this patient needs risk stratification. How to risk stratify patients with syncope in the next slides. After risk stratification, patient may be a high risk or a low risk. Low risk patients may be a low risk but with recurrent syncope, or a low risk with a single or rare syncope. Patients at low risk after risk stratification with single or rare recurrences, these patients needs reassurance, and most of them needs no further evaluation. But if the patients at low risk but high rate of recurrence of syncope, this patient needs ancillary tests and treatment. If the patient is high risk from the beginning in the ER, this patient needs early evaluation and treatment. How to risk stratify patients with uncertain diagnosis of syncope at the ER? Let's start with the low risk patient. Features of low risk syncope are mainly related to reflex syncope or orthostatic hypotension related syncope. On the other hand, the high risk features are mainly related to cardiac causes of syncope. And evaluation takes place during initial evaluation of the syncopal attack itself, and from past history, from physical examination, from ECG. The syncope itself, if it is associated with a prodrome like nausea, vomiting, or after sudden unexpected unpleasant sight, smell, pain after prolonged standing, postprandial, triggered by cough, with head rotation, with standing from supine, all these features are suggestive of reflex syncope or orthostatic hypotension or carotid sinus massage. These are all suggestive of a low risk syncope. Usually these patients have long history of recurrent syncope with low risk features with the same characteristics of the current episode, and on examination they don't have structural heart disease either by history or by examination, and usually their ECG is normal. What about high risk features? High risk patients with syncope, on evaluation of syncope itself, they have features suggestive of cardiac cause of this syncope, like new onset chest pain or breathlessness, syncope during exertion, syncope preceded by palpitations. These are high risk features. Or other features in the presence of structural heart disease or abnormal ECG, like family history of sudden patients coming with syncope and he has a family history of sudden cardiac death and he has structural heart disease. Patients who developed syncope in the sitting position in the presence of abnormal ECG or structural heart disease considered high risk. Patients with history of structural heart disease, coronary artery disease, if these patients presented with syncope, they are high risk. And on examination, patients with unexplained hypotension, patients with history or examination suggestive of bleeding, patients with persistent sinus bradycardia, patients with undiagnosed systolic murmur. And if you examine their ECG, you may find findings of cardiac structural disease, like ECG findings of acute ischemia, findings of advanced heart block, slow atrial fibrillation, persistent sinus bradycardia, bundle branch block, T waves consistent with coronary disease cardiomyopathy, sustained or non-sustained VTAC, dysfunction of a previously implanted pacemaker or ICD, type 1 ProGADA or long QT. These are the major features in the ECG that, if present, makes this patient with syncope is a high risk patient that needs immediate admission and treatment. These features are also high risk, but they are considered high risk features if the patient history suggestive of arrhythmic syncope, like if he feels palpitations before syncope, like Mobitz type 1 second degree AV block, asymptomatic inappropriate mild sinus bradycardia, heart rate from 40 to 50, paroxysmal SCVT or atrial fibrillation, pre-excited QRS, short QT syndrome, atypical forms of Brugada, not type 1, negative T wave suggestive of arrhythmogenic RV dysplasia. These are considered high risk if the patient's history suggestive of arrhythmic syncope. After initial evaluation in the ER of syncope, from examination, history, ECG, the patients may be a low risk or a high risk. Patients with low risk, mostly they are reflex syncope, situational syncope, or orthostatic hypotension. These patients can be discharged directly from the emergency department, and if recurrence occurs, they can be monitored in outpatient clinic. Patients at high risk, mostly they have a cardiac causes. These patients needs emergency department or hospital syncope observational unit. If these units are not available, patients have to be hospitalized to intensive care or intermediate care unit. Then, if they have high risk features, require intensive diagnostic approach, should not be discharged, and this patient should be admitted. If the patient does not have features of low risk or features of high risk, they are considered neither high risk or low risk, should not be also discharged. This patient should be either hospitalized or admitted to hospital syncope observational unit. And after proper workup, diagnosis, and starting treatment, all these patients can be transferred to outpatient clinic follow-up. These are the guidelines from the most recent guidelines for syncope, European Society of Cardiology 2018. It's class 1 recommendation that patients with low risk features likely to have reflex or situational syncope or orthostatic hypotension are discharged from the ER. Patients with high risk features receive an early intensive evaluation in a syncope unit or in the emergency department observational unit, or to be hospitalized if we don't have an observational unit. Patients who have neither high or low risk observed in the emergency department unit or instead of being hospitalized. Now, after initial evaluation of syncope, if the diagnosis is certain, start treatment. If the diagnosis uncertain, after history, physical examination, ECG, what is the likelihood of this syncope to be of cardiac origin? If cardiac likely, this patient needs echocardiography, ECG monitoring, external or implantable. You may need AB study, stress test, or coronary angiography. But if cardiac unlikely and recurrent episodes, these patients may need cardiovascular autonomic tests, ECG monitoring, external or implantable. If cardiac unlikely and rare episodes, these patients might not need further evaluation. What are the basic cardiovascular autonomic function tests? These are applied to patients in which they may have reflex syncope, orthostatic hypotension related syncope, or cardiac syncope is unlikely or not high likely. These include active standing test, Valsalva maneuver and deep breathing, carotid sinus massage, tilt testing, and ambulatory blood pressure. These are very important to be considered. Active standing test. You ask the patient to measure his blood pressure in the supine position, then after standing for 3 minutes, and you measure blood pressure and heart rate. What are the diagnostic criteria? Syncope due to orthostatic hypotension is confirmed when there is a fall in systolic blood pressure from baseline by 20 or more millimeter mercury systolic or diastolic by more than or equal to 10 millimeter mercury, or a decrease in systolic blood pressure to less than 90 that reproduces spontaneous symptoms. This means the patient develops reduction in systolic and diastolic blood pressure or diastolic blood pressure, and this reduction is associated with symptoms. If this occurs, it's class 1. It's class 2A if the patient developed asymptomatic reduction in the systolic blood pressure by 20 or more millimeter mercury, or diastolic by 10 or more, or a decrease in systolic blood pressure to less than 90, and the symptoms from history are consistent with orthostatic hypotension. It's class 2A. This patient developed asymptomatic. When you measured his blood pressure during standing, he developed reduction in systolic or diastolic or systolic blood pressure less than 90, but he didn't develop the symptoms. But from history, his history is consistent with orthostatic hypotension. It's class 2A. But if the patient developed syncope or symptoms associated with a reduction in systolic or diastolic blood pressure, it's class 1 diagnosis of syncope due to orthostatic hypotension. Also, in active standing, you can look for what POTS, postural orthostatic tachycardia syndrome. This postural orthostatic tachycardia syndrome should be considered when there is an orthostatic heart rate increase. The patient, after prolonged standing for 10 minutes of active standing, his heart rate increased by more than 30 beats per minute, or increased to more than 120. In the absence of orthostatic hypotension and symptoms occur, so this patients have postural orthostatic tachycardia syndrome as a cause of his symptoms. The second cardiovascular autonomic test after active standing is carotid sinus massage. After carotid sinus massage, we look for asystole for more than 3 seconds and or fall of blood pressure. If this occurs, asystole and or reduction of blood pressure by more than 50 millimeter mercury without symptoms, this is called carotid sinus hypersensitivity, not carotid sinus syndrome. Carotid sinus syndrome means asystole for 3 or more seconds and or reduction of blood pressure by more than 50 millimeter mercury associated with symptoms. This is carotid sinus syndrome. If the patient developed marked reduction of blood pressure and syncope without asystole, this is a vasodepressor form. If the patient developed asystole for 3 or more seconds, you give him atropine. If after atropine no symptoms, so after atropine the patient improved, so he has a pure cardioinhibitory form that improves with atropine. But if after atropine the patient still has syncope, so this is a mixed form of a vasodepressor and a cardiac inhibitory form. So carotid sinus syndrome may be a vasodepressor form, a cardioinhibitory form, or a mixed form. How to diagnose a mixed form? You give atropine. If the symptoms disappeared, it is a pure cardioinhibitory. If symptoms persisted, it is mixed form. This is an example of carotid sinus massage, and the patient developed syncope. Here, asystole occurred associated with a reduction of the blood pressure. This may be a cardioinhibitory or a mixed form. After atropine, no symptoms occur. So the symptoms and the reduction of blood pressure were all related to the asystole. So this form that improves after atropine is pure cardioinhibitory form. This is the other type. The patient also after carotid sinus massage developed asystole and reduction of the blood pressure, and we give him atropine. Heart rate increases, but syncope and the reduction in blood pressure persists. So this patient is a mixture or a mixed form, because improvement of heart rate did not avoid occurrence of hypotension and syncope. So it's a mixed form of carotid sinus massage. what the guidelines says. Carotid sinus massage is indicated in patients 40 years of age with syncope of unknown origin compatible with reflex mechanism. Diagnostic criteria: carotid sinus syndrome is confirmed if carotid sinus massage causes bradycardia, asystole, and or hypotension that reproduces spontaneous symptoms, and the patients have clinical features compatible with a reflex mechanism of syncope. The third test is the tilt table testing. The patient lies initially on supine position, then gradual up tilting of the table, then gradual down tilting of the table. And this is the normal response of the heart rate and the blood pressure. With tilt up, there is slight increase in the heart rate, slight increase in the systolic and diastolic blood pressure that gradually goes to normal after tilt down. In this test, you look for changes in blood pressure and the heart rate with tilting the table position from supine to upright position. This is a demonstration of reflex syncope. When the patient during tilt table test moves up, we have Cardioinhibitory response, the heart rate decreases, and also systolic and diastolic blood pressure decreases. So we have tilt-induced reflex syncope. This patient developed syncope during tilt up, and when the patient went back to his supine position, syncope improved. So this patient have a vasodepressor and a cardioinhibitory form. In pure cardioinhibitory form, you will find that there is a reduction in the systolic, mainly in heart rate, without this significant reduction in blood pressure. This is a tilt table test of a classical orthostatic hypotension. What do you expect? During a tilt table to the upright position, the patient developed progressive hypotension, the progressive reduction of systolic and diastolic blood pressure. However, because he does not have a cardioinhibitory, there is some compensation attempts with increase of the heart rate. So this patient developed syncope. He has orthostatic hypotension without significant reduction in heart rate. And this is called the classical orthostatic hypotension because the reduction in systolic blood pressure and diastolic blood pressure starts very early with tilt up test. The second type, less common, is the delayed orthostatic hypotension. Here, look, with gradual upright positioning of the table, there is very gradual decline in systolic and diastolic blood pressure that reaches its nadir very late. Unlike the previous one, when we have a significant reduction early, the classical orthostatic hypotension, and this is the delayed form of orthostatic hypotension. In both conditions, we don't have significant reduction on heart rate. And this is an example of mixed form of cardioinhibitory response and the vasodepressor response when the table tilts up. So this patient has a mixed form of reflex syncope, cardioinhibitory and vasodepressor. Sometimes during tilt table test, you diagnose psychogenic pseudosyncope. What happens? During tilt up, we have an increase in the heart rate, an increased systolic, increased diastolic blood pressure, which is normal response. However, the patients develop syncope. So this syncope is a psychogenic pseudosyncope. We don't have any hemodynamic causes to explain this syncope during tilt table test. The last one during tilt table is postural orthostatic tachycardia syndrome. During tilt table test, like during active standing, we have a significant increase in heart rate by more than 30 beats per minute in 10 minutes, while the blood pressure, systolic and diastolic, does not show decline. So this patient developed loss of consciousness, mainly due to significant increase in heart rate, which is called postural orthostatic tachycardia syndrome. So, the guidelines regarding tilt table testing. Tilt testing should be considered in patients with suspected reflex syncope, orthostatic hypotension, postural orthostatic tachycardia syndrome, or psychogenic pseudosyncope. The diagnostic criteria are reflex syncope, orthostatic or POTS, or psychogenic pseudosyncope should be considered likely if tilt testing reproduce symptoms. Positive test with symptoms, along with the characteristic circulatory pattern at class 2A. So a positive test should be associated with characteristic symptoms and the characteristic circulatory pattern of these conditions. Finally, regarding cardiovascular autonomic tests, is the basic is ambulatory blood pressure monitoring. The last one of cardiovascular autonomic function test is ambulatory blood pressure monitoring. Normally during sleep we have normal nocturnal dipping, reduction in systolic and diastolic blood pressure. However, in patients with autonomic dysfunction, they may experience non-dipping, no decline in the blood pressure during sleep, or even a reverse form of dipping, reverse increased systolic blood pressure. These findings are features of autonomic dysfunction. 24-hour ambulatory blood pressure monitoring is indicated and recommended to detect nocturnal hypertension in patients with autonomic failure. It should be considered to detect and monitor degree of orthostatic hypotension also. With ambulatory blood pressure monitoring, you can detect orthostatic hypotension and the supine hypertension in daily life in patients with autonomic failure. Now we come to patients with suspected cardiac syncope. We look for arrhythmias, tachyarrhythmias, or bradyarrhythmias and heart block, and we look for structural heart disease. To look for arrhythmias, we start with the resting ECG, then ECG monitoring in hospital, then Holter monitoring, then external lobe recorder, and finally implantable lobe recorder. And if we want to go more invasively, we ask for EPS study. What are we looking for to detect arrhythmias? During electrocardiographic monitoring, we look for asystole, and this includes sinus arrest, sinus bradycardia with AV block, and these types are most probably reflex, like Cardioinhibitory response to situational syncope and the carotid sinus hypersensitivity or carotid sinus syndrome. If the patient during monitoring develops sudden onset AV block, this is probably have intrinsic AV conduction disease, not reflex. Bradycardia is probably reflex, like reduction in systolic, reduction in heart rate by more than 30%, or an absolute figure of 40 beats per minute for more than 10 seconds. The definition of bradycardia consistent with syncope, that is most probably related to reflex. Type 3 is no or a slight rhythm variations. This means variations in the heart rate is less than 30% and the heart rate more than 40 beats per minute. In this case, you cannot decide whether these patients have bradycardia related syncope or not, and the etiology is uncertain. Type 4 is tachycardia, like progressive sinus tachycardia. You cannot diagnose the cause of syncope based on progressive sinus tachycardia. But if you find atrial fibrillation, SCVT or VT, these patients most likely to have cardiac arrhythmia. This is an example of electrocardiographic monitoring. During Holter monitor, the patient developed sinus arrest and developed symptoms. So these patients most probably have based on this. There's sinus arrest. This type may be reflex, cardioinhibitory reflex, or these patients may need EP study for intrinsic sinus node dysfunction. This type 1B, this patient developed sinus bradycardia, progressive sinus bradycardia, then AV block. These patients with sinus bradycardia and AV block may have reflex, cardioinhibitory reflex, syncope, or EV nodal and the sinus node disease. The third type is the patients during Holter monitoring suddenly, this is different, developed AV block. There is no sinus bradycardia and no sinus arrest. All of a sudden he developed AV block. These patients most likely to have an intrinsic AV nodal conduction disease. This patient developed sinus bradycardia. Resting heart rate was normal or even tachyarrhythmic, and all of a sudden he developed bradycardia. This patient is most likely to have reflex, cardioinhibitory reflex related syncope. Come back to our patient with transient loss of consciousness suggestive of syncope, and after initial workup we are uncertain of the diagnosis or of the mechanism of this syncope. If this patient after initial workup with uncertain diagnosis is considered high risk and arrhythmia likely, this patient needs in hospital monitoring. And if we cannot catch the arrhythmia during hospital monitoring, this patient needs implantable lobe recorder. If this patient's syncope is low risk and arrhythmia likely and the recurrent syncope, this patient needs implantable lobe recorder if available, or external lobe recorder or Holter monitor. If the patient has low risk and reflex likely, here reflex likely, not arrhythmia likely, need for specific therapy, in this patient we may collect implantable lobe recorder for specific therapy. For example, this patient may have a carotid sinus syndrome with cardioinhibitory response that may need pacemaker, for example. Before doing that, if we cannot reach the diagnosis, this patient may need confirmation with implantable recorder. We'll go to the guidelines to see what is written for all of this. In hospital monitoring, in bed is indicated in high-risk patients. Any high-risk patients with uncertain diagnosis and arrhythmia is likely, these patients needs in hospital monitoring. What about Holter monitoring? It should be considered in patients who have frequent syncope or pre-syncope, one or more per week. At least once per week to increase likelihood to be found in Holter monitoring. What about external lobe recorder? External lobe recorders should be considered early after index event in patients who have an inter-symptom interval early than 4 weeks. If the patient developed the recurrence of symptoms of syncope in less than 4 weeks, there is a high chance of to be recorded by external lobe recorder. But what about implantable lobe recorder? Indicated in early phase of evaluation patients with recurrent syncope of uncertain origin, absence of high risk criteria, and a high likelihood of recurrence within the battery life of a device. This is very important. A battery life of the device will decide if the patient is candidate for this form of investigation or not. It should be considered in patients with suspected or certain reflex syncope presenting with frequent or severe syncopal attacks like carotid sinus or situation or reflex syncope. Implantable lobe recorder may be considered in patients in whom epilepsy was suspected but the treatment has proven effective. These patients initially diagnosed as epilepsy for the cause of syncope, but after control of epilepsy with treatment he still developed syncope, so this patient may need loop recorder to detect arrhythmia as a cause for his syncope. Arrhythmic syncope during monitoring, whatever it is, in-hospital, Holter, external or implantable loop recorder, arrhythmic syncope is confirmed when a correlation between syncope and an arrhythmia is detected. This is a clear association between, or a correlation between symptoms and arrhythmia detected by the monitor. In the absence of syncope, arrhythmic syncope should be considered likely when periods of Mobitz 2 or 3, AV block, or ventricular pauses more than 3 seconds, or rapid prolonged SVT or VT are detected. These patients developed severe forms of bradyarrhythmia or severe forms of tachyarrhythmias in absence of syncope. So in this case, it's class 2A recommendation to have cardiac syncope related to arrhythmia. Okay. After non-invasive monitoring with Holter, external or implantable loop recorders, when to send patients for an invasive electrophysiological study. We usually send these patients if they are high risk and they have high risk tachyarrhythmia or high risk for heart block. For example, in patients with syncope and previous myocardial infarction, EPS is indicated when syncope remains unexplained after non-invasive test. These patients might have ventricular tachycardia, which may be induced during EP study. In patients with syncope and bifascicular bundle branch block, EP study is indicated or should be considered when syncope unexplained after non-invasive test to check for conduction defects consistent with a syncope. What about EPS-guided therapy for such patients? Based on the findings of EP study, either for induction of tachyarrhythmia or testing for a bradyarrhythmia, a decision for treatment may be given. Like in patients with unexplained syncope and bifascicular bundle branch block. It's unexplained. But in this patient, a pacemaker is indicated if you find a baseline HV interval more than 70 millisecond, or a second or third degree Hesper-Kinch block during incremental atrial pacing or with pharmacological challenge. So this patient has unexplained syncope, but he has a bifascicular block, and during EP study he developed advanced form of heart block. This patient needs pacemaker, class 1 recommendation. In patients with unexplained syncope and the previous myocardial infarction, it's recommended to manage induction of sustained monomorphic BTAC. If you induce the monomorphic BTAC, these patients may need either ablation or ICD or both of them. In patients without structural heart disease with syncope preceded by sudden and brief palpitations, it is recommended to manage induction of SCVT or VT, which produces hypotension or spontaneous symptoms, with appropriate therapy, like if you induced VTAC or induced EVRT, and when these tachyarrhythmias induced symptoms. So these are most likely the causes of syncope and its treatment. Now, come to patients with possible cardiac syncope, and we are looking for structural cardiac defects as a cause of the syncope. Echo is indicated for diagnosis and risk stratification in patients with a suspected structural heart disease. We are looking for provocation in patients with suspected hypertrophic obstructive cardiomyopathy, like for example 2D and Doppler echo during exercise in the standing, sitting or semi-supine position to detect provocable LVOT obstruction in patients with HCM and a history of syncope and arresting or provoked peak instantaneous left ventricular outflow tract gradient of less than 50. So a patient with hypertrophic cardiomyopathy and syncope needs provocation. To look for increased gradient across LVOT. What are the diagnostic criteria? Aortic stenosis, obstructive cardiac tumors or thrombi, tamponade, aortic dissection. These are the most probable causes of syncope when the echo shows typical features of these conditions. Many conditions can be diagnosed with resting or with exercise echo or with provocation. Exercise testing. When to ask for exercise testing in patients with syncope? Exercise testing is indicated in patients who experience syncope during or shortly after exertion. What are the diagnostic criteria? You look for second or third degree AV block. When AV block develops during exertional or even without syncope. If the patient developed with exercise second or third degree AV block, this patient is most likely to have an AV block related syncope. Reflex syncope is confirmed when syncope is reproduced immediately after exercise in the presence of severe hypotension, like orthostatic, vasovagal orthostatic syncope. This patient developed syncope immediately after exercise associated with severe hypotension. Is syncope per se is an indication for coronary angiography? Actually, no. In patients with syncope, the same indications for coronary angiography should be considered as in patients without syncope. Now we come to the final part of this presentation, which is treatment of syncope. And let's start with the most common form, which is reflex or a neurally mediated syncope, which includes, as we said before, which includes vasovagal syncope, situational syncope, and the carotid sinus syndrome. The first step and the class 1 recommendation is patient education and the lifestyle measures. Then, if it is severe and recurrent form, according to its associated features and the hemodynamics, you can decide treatment. For example, if this form is mainly low blood pressure phenotype, mainly a vasodepressor form, this reflex syncope is mainly associated with hypotension. This patient needs fludrocortisone or midodrine, for example, in addition to increased salt intake and proper hydration. If these patients have dominant cardioinhibition, on the other hand, not dominantly low blood pressure, these patients may need cardiac pacing. If these patients have orthostatic hypotension related to hypotensive drugs, you can stop, reduce these medications. If this patient have prodromes before syncope or not. If these patients have prodrome that allows him to do some maneuvers, yes, counterpressure maneuvers can abort syncope in these situations, and also tilt training is indicated. But if this patient does not have or have very short prodromes, no time to have counter pulsation maneuvers, so this patient may need implantable lobe recorder guided management. We'll see that. It's class 1 recommendation to explain the diagnosis of reflex syncope to the patient, to reassure him, to explain the risk of recurrence, to teach him to avoid triggers and situations that induce syncope, like prolonged standing, for example. If patients have medications that causes hypotension, like vasodilators or diuretics, modification or discontinuation of these medications should be considered. What about physical maneuvers? Isometric pressure counter maneuvers should be considered in patients with prodromes, so he has time to do these maneuvers to increase heart rate and blood pressure. Also, tilt training may be considered for education of young patients to avoid reflex syncope and orthostatic hypotension related syncope. Then example of counterpressure maneuvers like leg crossing, like hand grip, and you can see that hand grip counter pressure maneuver can increase the heart rate and increase blood pressure significantly. So this patient with reflex syncope, if he has prodromes like sense of nausea, warmth, coldness, any symptoms suggestive of a coming reflex syncope during this time before occurring of syncope, if the patient did this hand grip, he may abort or avoid this syncopal attack before it occurs. What about medical treatment for reflex syncope? Fludrocortisone, mineralocorticoid, may be considered in young patients with orthostatic forms of vasovagal syncope with low normal values of blood pressure in absence of contraindications. Midodrine may be considered in patients with orthostatic forms of vasovagal syncope. Beta blockers, on the other hand, are contraindicated in these patients. So this was the treatment for reflex syncope. What about treatment for orthostatic hypotension? First is patient education and the lifestyle measurements. Second is adequate hydration and increased salt intake. Then stop or reduce vasoactive drugs like vasodilators and diuretics. Then after lifestyle, hydration, salt intake, drug modification. If the patient still have symptoms, what to do? You can start with counter pressure maneuvers. The patient may need compression garments, head up tilt sleeping or tilt training. Medications like midodrine or fludrocortisone in orthostatic hypotension are class 2A recommendation, unlikely in reflex syncope where they were class 2B recommendations. According to the guidelines for orthostatic hypotension, it's class 1 recommendation to explain to the patient, to reassure him and to explain to him the risk of recurrence, adequate hydration and increased salt intake. And as we said, it's class 2A recommendation to modify his treatment, to teach him isometric pressure counter maneuvers, abdominal binders, head up tilt testing, sleeping, to uplift the head of the bed by more than 10 degrees, midodrine and fludrocortisone if symptoms persist after lifestyle and these non-pharmacological measures. It's class 2A recommendations. What about treatment of syncope due to cardiac arrhythmias? Syncope due to intrinsic cardiac sinus node dysfunction or AV block. If ECG documented bradycardia due to symptomatic sinus node dysfunction, so permanent pacing is indicated. Also, permanent pacing is indicated if the patient has documented second or third degree AV block. If the patient has bifascicular block but ECG undocumented bradycardia, so this patient has syncope and all the positive findings are just bifascicular block, it is recommended to subject these patients for EP study or implantable lobe recorder looking for bradyarrhythmia, whether reported or induced, and if so, this patient is indicated for pacing. So pacing is class 1 indication in patients with symptomatic sinus node dysfunction. Pacing is class 1 indication in patients with documented second and third degree AV block. It's class 1 indication in patients with positive EPS or implantable lobe recorder showing advanced bradyarrhythmias in the presence of bundle branch block. Patients with bifascicular bundled branch block and unexplained syncope. If this patient have an ejection fraction less than 35%, equal or less than 35% ejection fraction, this patient needs ICD CRTD, class 1 recommendation. If this patient has ejection fraction more than 35%, so this patient needs EP study. EP study may find either tachyarrhythmia or a bradyarrhythmia and treatment according to the findings. If the EP study is negative, so this patient need an implantable lobe recorder. If positive for tachy or brady, treat according. If not and negative, just follow up. Cardiac pacing is indicated when there is an established relation between syncope and symptomatic brady due to sick sinus syndrome or AV block, as we said. Pacing is indicated in patients with intermittent paroxysmal intrinsic third or second degree AV block, although there is no documentation of correlation between symptoms and ECG. Although there is no documentation of correlation, patients with syncope and intermittent advanced second or third degree AV block are indicated for pacing. On the other hand, cardiac pacing should be considered when a relationship between syncope and asymptomatic sinus node dysfunction is less established. It's class 2A. It's class 3 recommendation. It is not indicated when they have a reversible causes for bradycardia like hypothyroidism or drug induced. Cardiac pacing is indicated in patients with syncope, bundle branch block, and a positive EPS study or implantable lobe recorder documented AV block. Tachyarrhythmias. Patient with tachyarrhythmia and documented SVT or a VT. SVT either candidate for catheter ablation or antiarrhythmic medication according to the findings. Patients with VT may be candidates for antiarrhythmic medications or catheter ablation or ICD according to the type of ventricular tachycardia. Cath ablation is indicated in patients with syncope due to SVT or VT to prevent syncope. ICD is indicated in patients with syncope due to VTAC and ejection fraction less than 35%. ICD is indicated in patients with syncope and previous myocardial infarction who have VTAC induced during EPS. ICD should be considered in patients with ejection fraction more than 35% with recurrent syncope due to VTAC. It's a class 2A recommendation in these patients. When cath ablation and pharmacological therapy have failed or could not be performed. So ICD is class 1 recommendation in patients with VTAC and ejection fraction less than 35% or patients with previous myocardial infarction and they have VTAC induced during APS or patients with syncope due to VTAC. This patient needs class 1 recommendation catheter ablation. Antiarrhythmic drug therapy, including rate control drugs, should be considered in patients with syncope due to SVT or VT. We come to the end of this presentation. We spoke about different types of syncope, reflex syncope, orthostatic hypotension, and the cardiac syncope. And in cardiac syncope, we went through different tachyarrhythmias, different bradyarrhythmias, structural heart disease. Finally, when to send a patient with syncope for neurological evaluation. Neurological evaluation is indicated when syncope is due to autonomic failure to evaluate underlying cause. When you suspect orthostatic hypotension or orthostatic hypotension related syncope, that is related to autonomic failure, whether primary or associated with dementia, associated with Parkinson's disease. Neurologic evaluation is indicated in patients with loss of consciousness suspected to be due to epilepsy. So when you suspect epilepsy, send the patient for neurological evaluation. Send the patient when you suspect autonomic failure. Brain MRI is recommended if neurological examination indicates disease, not routine. If the neurological evaluation indicates a Parkinsonism, ataxia, cognitive impairment, this patient needs brain MRI. To look for primary autonomic failure, you may screen for paraneoplastic antibodies and antiganglionic acetylcholine receptor antibodies in case of acute or subacute onset of multi-domain autonomic failure. However, and it is worth mentioning that it's class 3 recommendation to ask for routine EEG, neck duplex, arterial duplex, CT or MRI of the brain in patients with syncope who are not likely to have a neurological cause for this syncope. Thank you very much. I wish you the best. And after these slides, we have plenty of supplementary slides that can help you very much in studying this subject. Wish you all the best. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.